Hi class, welcome to lecture number 13. Lecture 13 focuses on chapter 17 of our textbook, and that is the chapter that's on immunological disorders. So this is actually a fairly short lecture. It's really just an overview of the different ways that our immune system can go wrong and the mechanisms by which they go wrong. So these last four lectures in the class really have to do with our immune system, how we can manipulate parts of the immune system, and how we can use medication to help our immune system function. So let's go ahead and dive into this unit. So before we get into the particulars of how our immune system can dysfunction, let's kind of think again about what our immune system, the purpose of our immune system is. Remember that when our immune system is functioning appropriately, we can protect ourselves from foreign invaders or from foreign pathogens, while exerting as little damage as possible on our body, while maintaining homeostasis. I think the analogy that they give in your textbook is that um, if you think about like a sprinkler system in a building, if there's a fire that goes off, the sprinkler system could potentially cause more damage than the fire itself. So sometimes systems that we have in place to protect us can actually hurt us more than that which they're protecting us against. And so that's exactly what can happen when our immune system isn't functioning properly. We either have two situations occur. We either have poor protection, in the case of like immunodeficiencies, for example, or we can have extensive damage in the case of hypersensitivities. And then, of course, we can have a third situation occur where we have autoimmune diseases where we're actually we're using our own cells to actively damage ourselves. So this is kind of what I was talking about in the previous slide. We basically have three potential outcomes when our immune system isn't behaving properly. We can have an exaggerated response to something that really should not even turn on our immune system potentially. So these are things like allergies and when we have haptens in our system, and essentially we have an immune response to something that we shouldn't have. Not only we should not have an immune response to it, but that immune response itself is going to damage the host tissue in some way. On the other end of the spectrum, we have immunodeficiencies where we have some central part of our immune response doesn't work properly, and therefore we don't have protection against that which we're trying to protect ourselves against. And then we can have a misdirected response. In other words, our immune system has somehow focused its attention on self. Remember that a really, really important part of our immune system is that it tolerates self. There's that self-tolerance, and when we lose that self-tolerance, we're going to get an autoimmune disease. All right, so let's talk about hypersensitivities first. Let me grab my pen here. And hypersensitivities, another word for hypersensitivity is anaphylaxis, and that flaxis means, what is protection, I think. Yeah, flaxis is, I think, Greek or Latin or something, right, for protection, and ana usually means opposite. So it's when we're not, basically, we have something that's the opposite of protection. So hypersensitivities, there's four different types of categories, and we categorize these different hypersensitivities into these categories based on the mechanism of the response. We're going to talk, so that even though there's four of them, we're only going to talk about three of them. We're not going to discuss type 3. So you need to know type 1, type 2, and type 4. So this is table 17.1 out of your textbook, and this is a really good overview of the major kind of highlights of each of these types of hypersensitivity. So let's talk about type 1 first. Typically, when you think of allergies, if you think about that term hypersensitivity, most people in their mind think of allergies, and allergies are actually only one type of hypersensitivity, and they're usually type 1 hypersensitivity. So when you think of an allergy, you're probably thinking about type 1 hypersensitivity. So you're usually used interchangeably. Allergies mean the same thing, and it's really a response to an allergen. And an allergen is I can't talk. An allergen is an antigen that can cause an allergic reaction. So, what are I highlighted them in the book, like pollen, um, bee stings, peanuts. These are all considered allergens because they're not pathogenic, right? They're not bacteria. They can't multiply in our body. They shouldn't cause us harm. But because of the mechanism that I'm going to describe to you, they cause an inflated immune response, and that damages our tissues. So the thing that I really want you, when you think of type 1 hypersensitivities, when you think of allergies, The two kind of defining characteristics is that they're fast and they're mediated by IgE. So you really should think about something that is, when you think of an allergic hypersensitivity, that is within minutes, sometimes even within seconds, and is mediated by B cells. Remember, B cells are the cells that make antibodies, specifically IgE. This is a type 1 hypersensitivity. So allergies always, again, they happen very quickly, and this is because of the mechanism, the pathway that this allergic response takes place within. So in order for a type 1 sensitivity to occur, we have to have prior exposure, and the allergic reaction is not going to occur until that second exposure. And this is because, and I'll show you this in the next slide, what happens is IgE, when it binds to that allergen, it's going to immediately activate the mast cells or basophils that it's bound to, and then they're going to degranulate, expose, dump all of these inflammatory chemicals, histamines, leukotrienes, into the environment, and that's going to cause inflammation. And in severe cases, it can lead to anaphylactic shock. Usually, I know there's asthma, for example, is a type of allergy that happens in the lower respiratory tract, and inflammation can occur there when you're breathing in an allergen. So, interestingly, I think I've always been fascinated by inherited mechanisms of immune dysfunction, because one of the things that I think is so interesting about allergies is that the sensitivities is inherited, but the type of allergen isn't. So if you have, for example, if you have parents that are highly allergic to pollen, you are more likely to have an allergy, but it can be to anything. The type of allergy isn't inherited. It's just the allergy, like the proclivity to have the allergy is, which I think is really interesting. Like it shouldn't, if I always felt like those should match up. So let's go ahead and look at the mechanism. So this is what happens. So we have a primary exposure that primes the response, and a secondary exposure that's going to happen at some later point. So let's talk about the primary exposure first. We have this allergen. You can see the allergen is recognized by a B cell, and we have activation by a helper T cell. Remember that we can't have a proper B cell response without help from those helper T cells. So this is where kind of our immune system is overacting. Our T helper cells really shouldn't help that B cell here, because that allergen is not, is not posing a proper threat to the immune system. So we have our kind of first mistake right there. The B cell is going to proliferate, undergo class switch. Remember that initially B cells secrete IgM, and when B cells in these type 1 hypersensitivities are going to switch pretty much exclusively to IgE. And if you recall from a couple lectures ago, IgE is an evolutionary holdover. We don't use it very often, and now for most people it really just causes problems. And so what happens here is the B cell is going to proliferate, it's going to create these antibodies, and it's also going to create memory cells. Now, these antibodies should go away, right? Like remember that IgG is very long-lived. It lasts for a month, maybe 2 months at the most. But most antibodies are typically short-lived. However, what happens with these antibodies is they're going to find their way to a mast cell, or I think they can bind to basophils as well. But mast cells are enough. And mast cells will bind the Fc portion of these IgE antibodies. And now this cell with this complex antibody can last for a pretty long time. And this is where that second exposure comes in. This can happen weeks later, months later. And then of course, upon, increased exposure, I mean, we're always, if you have an allergy, you know how this works. We're always being exposed to these things, right? It can even be years later. So as soon as we re-encounter that these allergens, those allergens are going to cross-link with the IgE that's already on the surface of these mast cells. And that cross-linking is all we need, all those mast cells need to degranulate and release all of those pro-inflammatory molecules into the environment. And that's why this happens within minutes, even seconds of exposure. We don't, again, remember that in a typical infection, that adaptive immune response doesn't even occur at the earliest, maybe like 2 days after exposure, because we have to go through B cell activation, helper T cell signal response, signal amplification, plasma cell development, all of those kind of steps that is in the typical adaptive immune response. We're bypassing all of that because those IgE antibodies are already on the mast cells. So of course the classic response to allergies is to take an antihistamine, and of course that's because antihistamines counteract the molecular mechanisms of histamines. All right, let's talk about type 2 hypersensitivity. So if we, let me think how fast type 2 hypersensitivities are. I'll just look it up. Mediators, fast, type, timing of reaction, hours to days, right? That's what it says. Let me look. Yeah, hours to days. Great. Okay, so the difference, so type 2 hypersensitivity is also mediated by antibodies. So in other words, we're still thinking about B cells. This is going to take a little bit longer. It's not the seconds to minutes that type 1 hypersensitivities are. But and so let me back up for just a second. If we think about type 1 hypersensitivities, I want you to think about fast, the fact that it's B cells, specifically IgE, and its big problem, if you will, is inflammation, which is really dangerous. Again, this can severe type 1 reactions can lead to anaphylaxis and shock and death, right? We've heard of people who have to carry around an EpiPen in case they get stung by a bee, or how serious peanut allergies can be, for example, right? Your airways can get restricted so quick that they close and you suffocate. So in contrast, type 2 hypersensitivity is not as fast. So let's just say intermediate. It's also B cells, but in this case, it's going to be IgG. And instead of inflammation, it's actually direct cellular destruction. And I think they call it cytotoxicity. Yeah, it's the cytotoxic response, or another name for type 2 hypersensitivities is cytotoxic hypersensitivity. Oh my goodness, this is like the 6th video or a voiceover I've tried to do today, and I can't talk anymore. Cellular toxicity, or cytotoxic hypersensitivity, because this is going to lead to direct destruction of cells and tissues. 2 examples that I'm going to talk to you about, and that is very important when you start practicing medicine, is going to be transfusion reactions and hemolytic disease of the newborn. What happens here, on a very basic level, is that we have IgG that is going to recognize and bind to a particular epitope. If you recall, antibodies don't really do much on their own. They might agglutinate and cause some opsonization, agglutination of cells or bacteria and so on, but they're not directly cytotoxic themselves. Ask yourself, do you recall what is it that antibodies activate that can lead to toxicity? Well, there's actually 2 things. Remember that antibody can activate complement, and then complement will do the MAC attack. It also does opsonization. There's 3 outcomes. Opsonization for macrophages, and what's the third one? Opsonization. I can't think of it. Complement. Inflammation. Right, the 3 outcomes of complement activation. So antibody IgG in particular, I think IgM also does this, but IgG is really good at activating complement. So it can recruit complement, and the big one, of course, is that complement will form that MAC, that membrane attack complement, and kill the cell. The other thing that it does is it recruits natural killer cells, and this will activate antibody-mediated direct cellular cytotoxicity. What does ADCC stand for? Antibody dependent, that's what it is. Antibody dependent cellular cytotoxicity, so ADCC. So there's two downstream consequences of these IgG antibodies recognizing these epitopes. First, complement. Second, natural killer cells. So before we talk a little bit, so now that we understand that it started by IgG and it leads to destruction of cells. So here is one potential outcome of that, and that is when blood transfusions are not matched correctly. So before we can talk about this, let's talk about blood types first, because we don't know really, we haven't talked about this yet. Remember that you can be 4 different types of blood: type A, B, AB, and O. And so A and B stand for specific polysaccharides that are on the surface of our red blood cells. And so if you're type A, you're going to have that A polysaccharide. And if you're B, you're going to have the B polysaccharide. And if you're AB, you're going to have both. And if you're O, you're going to have neither. So if you're type A blood, you're not going to have antibodies that recognize A. That would be recognizing self, and that's bad. So the only antigen that you're going to recognize is B. So if you are type A blood, you're going to have anti-B antibodies in your system, because B, you don't recognize B. You've never heard, your immune system has never heard of the B antigen on red blood cells. Likewise, if you are type B blood, you're not going to have antibodies directed against that B polysaccharide, that B antigen. You're going to have antibodies directed against A. Now, if you're very lucky and you have type AB blood, you don't have antibodies to either A or B because you have both of them, right? You recognize both as self. And group AB, people who are type AB, are called universal acceptors, right? Universal recipients, we'll just put acceptors. Sorry, I keep pushing the button on this thing. Universal acceptors, because they can accept any type of blood. They can accept all 4 types of blood if they need a blood transfusion, because they don't have antibodies to any of them. On the other hand, people with group O, type O blood, they don't have either antigen on their surface, so they, unfortunately for them, have both they have both A and B antibodies in their bloodstream. So they can only receive type O blood. They're called, so who can group O give their blood to? Well, they have no antigens on their, at least no A and B antigens on their surface. So there's nothing to react against. In other words, they are considered universal donors. Type O blood is pretty, like if you're type O, if you have type O blood and you go to donate blood, they will call you. They're going to call you and be like, can you come in? And, and they'll try to get you to come in as much as you can, because it's really good blood to give around, because they know they can give it to anybody. So why is this a problem, right? Why do we have to worry about the antigens that are on blood groups when we do transfusions? Because, of course, if your body recognizes these red blood cells as foreign, we're going to mount an immune system attack against it. So if I have type A blood and I receive type B blood, my IgG antibodies are going to recognize those, excuse me, are going to recognize those antigens on the surface of the blood transfusion. And at the very least, what's going to happen is they're going to be destroyed by the complement and the natural killer cells. And basically that blood transfusion didn't do very much good. Now, at the worst, like, so that's the best that can happen, really. And at the worst, you can have extensive damage. Basically, all of the damaged cells start to build up in your blood vessels. They can lead to kidney damage. And in extreme cases, the patient can actually die from receiving an incorrect blood transfusion. So it's very, very easy to check for this. And this is why we always screen patients for blood types before any type of surgery, or most people, you really should know your blood type also. So when you talk about blood transfusion incompatibilities, this is a type 2 hypersensitivity issue. Another issue that I think is an interesting illustration of how our immune system works is a disease called hemolytic disease of the newborn. And it's not really a disease, it's really a dysfunction. Again, it's an immune system dysfunction. You can't catch it. But in order to understand how this works, we have to talk about another aspect of the red blood cells, and that is the Rh factor. So we have our typical ABO blood types in people. So we have those 4 different types, but you can be all 4 of these types and be Rh negative or Rh positive. So all of these, of course, are negative and all of these are positive. So Rh is another antigen that is on the surface of people who have Rh positive red blood cells. So again, you can see that we still have our standard ABO blood typing, but people who are positive have these Rh carbohydrates or polysaccharides on the surface of their red blood cells. So again, just positive or negative. So let's imagine that we have, and this is very interesting because I'm definitely going to ask you a question about this on the test in terms of how this works. So let's kind of set the scene. We have mother and a father, right? And the mom has to be Rh negative. Mom has to be Rh negative. The dad has to be Rh positive. See that right there? Otherwise, this isn't going to work. If it's either or, this is not an issue. So we have to have first we have to have these 2 conditions occur. Mom has to be Rh negative. If she's Rh negative, that means that she could, upon exposure to the Rh antigen, produce Rh antibodies against that antigen. So her first pregnancy, she has a baby that is Rh positive. Now, during the process of birth, during delivery, some of the baby's blood will, and antigens basically, will mix with the mother's blood. And that allows that Rh antigen to get into the mother's system. Our immune system, or the mother's immune system, I should say, has now been alerted to this new antigen. This is going to cause our immune system to create memory cells, memory B cells, that recognize that Rh antigen. So far, everything's okay. Baby's fine, mom's fine, but she now has these memory B cells that can specifically recognize the Rh antigen. Months later, years later, whatever it might be, the mom gets pregnant again, and this time the baby is also Rh positive. Remember that IgG can cross the placenta, right? So the mom has these Rh specific antibodies that are in her system, and they're going to recognize the red blood cells in the baby. They're going to destroy them, right? They're either by natural killer cells or by activation of complement. Now, believe it or not, this is not that big a deal while the baby's in utero, because the mother can easily replace those red blood cells while the baby is developing. What happens is after birth, the baby there is no longer an exchange. And what happens is the newborn baby can't clear all of the damaged cells because the IgG is still there and it's still activating the complement. Because remember, complement is a portion of our innate immune system. So the baby has complement. And so those antibodies are activating complement. The baby's red blood cells are getting destroyed, and it's very, very quickly going to become anemic. And if it's not figured out quickly, the baby could die. So let's just think about the situation that has to occur. If the baby's Rh negative, this doesn't happen. If the dad's Rh negative, this doesn't happen. If the mom's Rh positive, this doesn't happen. So it's a fairly specific set of circumstances that has to occur in order for this to happen. But it's common enough that a medication, basically a therapeutic, has been developed to prevent this from happening. So basically the mom gets an infusion at some point during her pregnancy, and I think maybe right before delivery, I can't remember, and then that basically gobbles up all of those Rh specific antibodies that the mom is producing. So I just think this is a really cool application of the fact that scientists figured out how the immune system works, how the immune system is not functioning correctly in this case, right? Because the immune system thinks that it's doing a great job, right? I mean, the mom's, memory B cells are like, look at all of this protecting I'm doing. I'm saving you from this pathogen, but the pathogen is her baby and it's not working. It's not good. So this is, I guess it's weird to think of being pregnant as a hypersensitivity, but in this case, the B cells are right. They've turned into these plasma cells that are secreting these antibodies that are actually hurting the baby's red blood cells. All right. The last hypersensitivity that we're going to talk about is type 4 hypersensitivity. And again, let's think about what we need to think about with this one. It's slow. This actually happens after, I want to say maybe like 2 days, a day, at the earliest, maybe a day. It's mediated by T cells instead of B cells this time. And this is both inflammation by helper T cells and cytotoxicity, so direct destruction of cells by the cytotoxic, the cytotoxic T cells. So these are those CD4 positive T cells, and these are the CD8 positive T cells. This is the main one. This is the big one, but a lot of people forget that helper T cells play a role in type 4 hypersensitivities as well. Type 4 hypersensitivities, the two main applications are contact dermatitis, so latex allergies, poison ivy. Some people are allergic to nickel, like there's certain metals that cause problems with when they come in contact with your skin. And another big application of type 4 hypersensitivities is graft and organ rejection. So they don't recognize these T cells will not recognize the major histocompatibility complex, MHC, on that transplant, and will directly attack that transplant. So let's look again the mechanism of what's happening. Remember, I haven't really defined this term hapten yet. Remember, we have an antigen. An antigen is something that an antibody can recognize. An allergen is an antigen that causes an allergic response. And a hapten is a very small molecule that will cause an immune response only when combined with other peptides. So it's kind of a strange, nobody really understands why certain molecules are haptens and other molecules aren't. But what happens here is we have this little, so these molecules are very, very tiny. They're small enough to go through our skin, right? They can pass through those really tight junctions of our dermis, and they get through those, that dermal membrane, and they get taken up by our dendritic cells. Our dendritic cells and our macrophages, our antigen-presenting cells. This is going to complex a hapten with some self-peptide and present that to our T cells, our helper T cells and our cytotoxic T cells. Remember, these are the CD4 positive T cells, and these are CD8 positive T cells. So now that we have activated T cells, our helper T cells are going to go to other parts of our immune system, mainly our macrophages, and activate our macrophages to induce inflammation. So this is where we get that inflammation upon contact with things like poison ivy. On the other hand, our cytotoxic T cells are going to destroy any skin cells that are also presenting this hapten peptide complex. Because remember that these cytotoxic T cells will dump things like granzymes, and what's the other one? Perforins, right? They directly, The screen moves when I try to write. There we go. Perfect. And that's why it takes a little bit of time for this hypersensitivity to present itself, because it's all through our adaptive immune response. Remember, our T cells, cytotoxic T cells, and our helper T cells are adaptive immune system participants. All right, so we're done with hypersensitivities. Now let's move on to autoimmune diseases. Let's remind ourselves that how should I do this? Okay, I'm going to skip over T cells, but let's use B cells as an example. The same thing happens with T cells, but let's recall that when B cells are in the bone marrow, they need to make that B cell receptor, right? You can see the B cell receptor are these little bottom guys hanging off the cells. Now remember that B cell receptor is completely random. Organization of that protein, expression of that gene is completely random. It has to do with V, D, and J recombination. And most of the time, those B cell receptors are garbage and they don't do anything. Sometimes they recognize self. We got to get rid of these guys. We really want to delete these in the bone marrow before they get out into our system, because we don't want B cells that recognize self-antigens to get out into our body. Same thing with T cells, except that this happens in the thymus instead of the bone marrow. If this doesn't happen, if we can't delete these B cells, we have an autoimmune disease. Occasionally, when these self-reactive B cells and T cells get out, they can be deleted in the secondary lymphoid organs, but they still can cause some problems. Some of the autoimmune diseases that occur as a result of this inability to destroy self-reactive B cells and T cells are things like type 1 diabetes. Essentially what happens here is our cytotoxic, and we have antibodies that recognize beta cells in our pancreas, and the beta cells are the specialized cells in our pancreas that make insulin. And so we get these antibodies that recognize. Why do I feel like it's also cytotoxic T cells? I feel like cytotoxic T cells recognize the beta cells, and that's what destroys them. Let me look this up really quick. Yeah, it is cytotoxic T cells. That's what I thought. Cytotoxic T cells, remember, also form a TCR. And so those T cell receptors can also recognize self if they're not deleted in the thymus. And so when those CD8 positive T cells that recognize our beta cells kind of latch onto them, they're going to secrete those granzymes and perforins and directly kill those beta cells. And if we don't have beta cells, we can't make insulin. And so we're forever on a outside supplement of insulin for the rest of that person's life. Other examples of autoimmune disease are things like Graves' disease. Graves' disease is really interesting because what happens here is we have an antibody that is specific for a receptor on our thyroid. This also is very common in women and not very common in men, which also I think is fascinating. Like, why would an autoimmune disease be more common in one gender versus another? So in Graves' disease, what happens is the antibody recognizes a receptor on the thyroid, and it actually stimulates the thyroid. And sometimes what can happen is it stimulates it so much that the thyroid actually enlarges and forms a goiter in your neck. So one of the kind of signs of Graves' disease is that you have this enlarged kind of lower neck area, and sometimes it can be really big. You're tired, you're irritable. There's lots of. It's a fairly easy. I shouldn't say that. It's actually a fairly tricky disease to identify. Once it's suspected, it's very easy to figure out what it is, because you can look for these self-reactive antibodies. And unfortunately, I want to say that the only way to fix it is to destroy the thyroid, and then basically give you take some radioactive iodine that kills your thyroid, and then you have to be on artificial hormones. I forget the name of the hormones that your thyroid releases, but you have to take those for the rest of your life as well. So, the only real way to fix autoimmune, there's no cure for type 1 diabetes. You basically have to supplement yourself with insulin for the rest of your life. Similar in Graves' disease, really. Like, you can't, there's no fix for it. You just have to supplement what you're missing. But for things like rheumatoid arthritis and myasthenia gravis, the way to treat and most other autoimmune diseases is to limit the immune response. So you're basically on some type of immunosuppressive drug for the rest of your life. Okay, so on the other hand, we have immunodeficiencies, and there's two major types of immunodeficiencies. There's primary immunodeficiencies, which are genetic in origin, and so thus they're present at birth. And there's two types of primary immunodeficiencies. You can have a deficiency in specific antibodies, typically it's IgA, or you can have a deficiency in entire lymphocyte lines. In other words, you could potentially not have B cells or not have T cells, which is a big problem, as you can imagine. So in the case of antibodies, there's a type of disease, I don't recall the name of it off the top of my head, but essentially you can't make IgA. And as you can imagine, remember that IgA is the main, it really doesn't serve a big function in your blood, but it serves a very big function in your mucosal membranes. And so IgA is found in your mucosa right now. If you were to take a sample of your saliva, or do a swab of your throat, or your genital tract and so on, you would find IgA antibodies. And so in people that don't have who have the inability to make those IgA antibodies, they constantly are getting basically infections of their epithelial membranes. They're getting lung infections, lower respiratory tract infections, urogenital tract infections, and so on, because they don't have that protection of the IgA that is so important in maintaining that physical barrier to infection. Much, much worse is when you can't make lymphocytes. If you can't make B cells and T cells, or either or, you're in big trouble. And we're going to talk about that in the next slide, and there's a short video that you can watch as well. The second type of immunodeficiency is secondary immunodeficiencies, and these are the type that are acquired at some point in your life, either through an infection. For example, if you contract HIV, your CD4 positive T cells, your helper T cells, are destroyed, and that limits your immune system's ability to mount an effective response. And of course, you start to an advanced state of HIV infection is the disease AIDS, which is acquired immunodeficiency syndrome. Another way you can acquire a secondary immunodeficiency is through a malignancy, of course, through cancer. So the cancer itself could limit your body's ability to mount an effective immune response. But don't forget that you can also, the therapy, the cure, sometimes, again, the sprinkler system is sometimes worse than the disease in a way. The therapy itself will severely affect your immune system. And, right now there's so many people, thinking about the COVID situation that we have right now, there's so many people that have suppressed immune systems because they either have or have had cancer, and they are immunosuppressed in some way. Other stresses that can be acquired, don't forget that stress itself is a stressor. And so when someone is severely stressed, that can lower their immune system function. And then, of course, if we take immunosuppressive drugs, if we had a transplant, an organ transplant, or a graft at some point in our life, and we are on some type of immunosuppressive drug, you're going to have some type of immunodeficiency. So I mentioned in this slide, one of the primary immunodeficiencies is called severe combined immunodeficiency. And what happens here is it's typically, so it's almost always some type of genetic mutation that causes our lymphocytes to not mature and basically not get out of the bone marrow. I think there's some immunodeficiencies where the T cells can get out, but they don't get past the thymus. But essentially, to not make it too complicated, our lymphocytes are unable to develop properly. So we have no B cells or T cells, and sometimes in severe cases, both. And usually, typically what happens here is there's some gene that is incorrect that doesn't allow the B cell receptor or the T cell receptor to develop correctly. And if those don't develop, we don't have B cells or T cells. There was I'm trying to think, all you guys are way too young to remember this, but there was a mini series that was really popular in the 80s was called The Boy in the Bubble, and it starred John Travolta, and he had SCID. He had severe combined immunodeficiency disorder because in the past, these children would die. They would basically have to be kept in a very sterile environment, and they would literally live in this bubble. They would live in a hospital room that was, ventilated. All the air was constantly, passed through basically one big N95 mask, because they couldn't have any type of infection. They were so sensitive to infection and pathogens. They couldn't touch people. They couldn't really interact with people in any way, and it was just a terrible way to live. There has been some really interesting advances with gene therapy for severe combined immunodeficiency disorders, and if we were in class, we would watch this quick video and talk about it and talk about how this therapy works, but I'm just going to let you watch the video for your own enjoyment. I think that does it. That's the last, yeah, that was the last slide for this lecture, and I'll post, like I said, I'll post this video in on the page for this lecture.